Morning, everyone. We're going to get started here. Thank you for coming, and thank you for those who have joined online. This is our 2024 Kevin Graham Lecture. So we do this every year to honor Kevin and his initiation of our prevention program here at MHI. And he started in 1998, so we got a number of years under our belt. We'd like to thank our sponsors, Amgen and Bristol-Myers Squibb. And this lecture has a long history of a pretty high bar. We've had some really good speakers throughout the years, and I'm not too worried that our current one will bring it down at all. He's excellent. So Dr. Amit Khera has a pretty long bio. If I'd read it all, we wouldn't get to his talk very soon. So I'll summarize briefly. He trained in med school at the Baylor College of Medicine. He did internal medicine residency at Brigham and Women's out in Boston, and then did his cardiovascular fellowship at UT Southwestern, where he then stayed on as faculty. He's currently the director of preventive cardiology at UT Southwestern. I believe they just celebrated their 20th anniversary there. He's also associate chief of cardiology for faculty development. He's got a long history of success in research and leadership. He's the past president of the American Society of Preventive Cardiology. He's an associate editor for Circulation, and he's the current chair for the 2024 AHA Scientific Sessions. And so today he's going to talk to us about familial hypercholesterolemia, a new era in diagnosis and treatment. Dr. Khera.
First thing, I want to thank Dr. Minima. He's someone I've known for quite some time. We got to be on the 2019 prevention guidelines together, and I don't have to tell you what an amazing person he is, what a great doctor and individual. So it's really a privilege. I had a great dinner last night, got to meet some people, hear a little bit more about the area, learned about some sushi in the strip mall and some neat stories. So it's been a great evening. I want to acknowledge this named lecturer. I've not had the privilege of meeting Dr. Graham, but I've read a lot about him. I actually watched some videos online just to get to know what he's about, and certainly a visionary, someone who started prevention well before prevention was a thing, and so someone who certainly I would love to get to know at some point for all the contributions he's made. So it's truly an honor in his name to provide this lecture. So today I'm going to talk to you a little bit about FH. That's a mouthful, so I'll just use it as FH, something that is near and dear to my heart, and I'll always, when I give Graham rounds, I always like to start with a case and really make this somewhat patient-based. And we'll come back to this individual later. So you may see this person, a 46-year-old male, presents for an annual PCP visit, has a history of dyslipidemia on a statin for about 10 years. He's married, has 2 children, ages 14 and 16, no tobacco use. His family history is notable, and this is something we always want to pay attention to. Mother with bypass at 62 and a maternal grandfather at MI in his 50s. He has 2 younger siblings, and as always, we don't know our siblings' history, and that's something we talk about at family reunions. He's on a atorvastatin, 20 milligrams daily. His exam is really, he's overweight, but not really notable for much else. And then when you look at his labs, you see his labs down there, his LDL's 107. So let's keep this patient in mind. I'll use him throughout and then come back to him at the end. I was talking to, I see Otto here, I was talking about history. I was an American history major. So I'd like to go over the history a little bit about FH. And that history, I'm at UT Southwestern in Dallas, and these 2 gentlemen were our first 2 Nobel Prize winners, Brown and Goldstein. They're still alive. I'll show you a picture in a minute. And their story began in 1968, where they met at the NIH and were studying familial hypercholesterolemia. And this is one of the early patients, homozygous FH. You can see this young child had xanthomas, the cholesterol buildups on her tendons. And at that time, there was no treatment. Statins only came out in 1987. So unfortunately, this was essentially a fatal disease back then for young children. And so their partnership started in 1968. It continues today. They ended up figuring out that this disease was caused by the LDL receptor defect, so it doesn't bind to LDL and take it in the liver. They also discovered that with the foundational work on cholesterol, that led to the discovery of statins and many other things. A really cool thing is just a couple of weeks ago in Dallas, the Family Heart Foundation had an annual summit. It happened to be in Dallas, and they honored Drs. Brown and Goldstein. What I want to show you, which is pretty neat, they're obviously still alive. There's Dr. Goldstein, there's Dr. Brown. But this woman was one of their initial patients in the 60s and 70s. She's in her late 50s now. She had a total cholesterol of 900. Her brother died at 15 from coronary artery disease and valve disease. And she is still alive thanks to modern medicine and all the treatment. She was just in time to get a lot of that. Has had plenty of surgeries, but pretty cool thing that we'll probably never see all these 3 together on stage again, so very neat. Well, let me define familial hypercholesterolemia for you because it can mean lots of things. And so for the purpose of this talk, what it means to me is severe hypercholesterolemia, LDL above 190, but autosomal dominant, meaning 50-50 every generation will inherit this. There's some genetic basis. I'm going to talk a lot about genetics during this talk, but these are the sort of big three genes if a gene is involved, with, again, the LDL receptor classic, what Brown and Goldstein found. And then in terms of prevalence, most of my talk today is really on heterozygous FH. I do take care of a few homozygous FH patients, and you all have some as well, as I know. This one's more rare, about 1 in 500,000. So I always tell everybody, theoretically, there's only about 600-700 people like this in the United States. So we have to remember that. But this is 1 in 250 with LDLs generally in the 200 to 400 range. A little bit more about this prevalence and implications. This 1 in 250 numbers, plus minus, I'm going to share some of your data in a little bit, seems to be similar in whites and blacks. And this one study out of NHANES seemed to be a little less prevalent in Mexican Americans. Not clear if that's true or just the data set. But about 1.2 million people in the United States have FH, 1.2 million. This is not rare. And I know there's lots of cardiologists and fellows in the room. If you take care of patients with acute coronary syndromes, somewhere between 2 to 5% of every patient you have with acute coronary syndrome has FH. So should be thinking about it. 1 in 20, 1 in 50, you will see 20 or 50 patients with acute coronary syndromes this year, I'm certain. And here's why we care. Because the cholesterol is so high from birth, there's about a 5 to 20-fold increased risk of coronary heart disease. So really an important health problem. It's not rare, but for lots of reasons, as we'll talk about, it's just not diagnosed and addressed appropriately. So a little bit about underdiagnosis. Now, this is sort of across the world. This is a little bit older data. Everyone always talks about the Netherlands, and I always say the Netherlands is probably smaller than Texas, and it's pretty homogeneous. So what they have a great national screening program in that you find one person, they literally get in their car and drive and find all their family members. So they have diagnosed it very well because of their population. But most places around the world, now this number keeps changing, but it's probably less than 20% in the United States that are diagnosed. That number's not exactly known, but most people that have FH don't know they have it. It's not well diagnosed. So this is a real opportunity, which I hope to bring out today, about what are we doing today to improve this. This is since 1985, they won the Nobel Prize. The numbers are still poor. So what is new? What are we doing now to help in this diagnosis? I'll cover that a lot in this talk today. All right, so a little bit about clinical FH for those that don't manage as many patients with FH. I just want to talk about how one makes the diagnosis. We'll talk about genetics in a little bit, but when it comes to clinical, these are all really largely research criteria. Simon Broom, Dutch Lipid Clinic, US MedPed, if you're not familiar with them, but they're all really more to enter. It's clinical, but it was largely from research so that you would know entry criteria into these studies. I like Simon Broom just because it's easier. It's not hard to remember. And basically, if you're out seeing patients today, I know Dr. Meadham was driving out to see some patients today, he won't miss this, but if someone has an LDL above 190, you should start thinking about FH. Does not mean you have it, and actually, only about 2% of people, depending on what you read, above 190 have FH. So it doesn't mean you have FH if it's above 190. You also, if you have tendinous xanthomas, which I'll talk about, or a mutation, then we call that definite FH. If you have a family history or high cholesterol in your relatives, then it's possible FH. But the bottom line is above 190, you should think about it, and then you need a few other things to help make that diagnosis clinically. So hopefully this spurs things, and we'll come back. Keep that case in mind that I gave you. You're probably saying, well, his LDL wasn't above 190, and we'll talk about the trick there a little bit later. All right. So I love the physical exam still. I used to teach the medical student physical exam lecture for years. And this is one of my favorite things, is tendon xanthomas. If you look at the Achilles there and on the knuckles, and I love it because this is why. If you're in your office, it's one of the few times, other than if you hear critical AS, it's one of the few times where you actually change the life of that person and their entire family on your physical exam. Because if you diagnose, there's only about 3 things that can give you tendinous xanthomas. This, acetosterolemia, and CTX. It's not many things that can give you tendinous xanthomas. When you feel them, whenever I find a new patient, if I don't have a fellow with me, I go find someone in the clinic, even if they're not in cardiology. Just bring them in. You got to feel this because you don't see them as often. And one thing about them, even though we talk about xanthomas, you'll notice the patient case did not have xanthomas. They're actually more rare. They're less common than average, meaning the old mantra was age minus 10%. So if he was 46, then he had a 36% chance. But that's old data when we did not treat people as much. Now that everyone's on statins earlier, they do shrink, by the way, with treatment. And so that prevalence has decreased. And this is why some of our scoring, like Dutch Lipid Clinic, which involves like tendinous xanthomas, we don't see them as much anymore. And so this throws off our criteria, if that makes sense. The other thing is corneal arcus. We always talk about this around the cornea. But remember, that's only in older people, that's a normal finding. It's really in younger individuals less than 45 where it's pathologic. And same with these xanthelasmas. Under 25 is when they end up being pathologic. Now you can have these without FH. I was telling the story, my son's a Boy Scout. There's a guy in one of the adults that has these, and we were going on a hiking trip to Philmont for 10 days up a mountain, and I thought, oh my God, I'm not going with this guy because just in case. But he is perfectly fine actually, and you can have these without having, so this does not mean you have FH. So a little bit about treatment, just setting the groundwork for some other things we're going to talk about. You know, the thing about it is you can imagine you can't do a randomized trial. It's not ethical to untreat. So largely, if we'd say, does treatment help? Now you may say, of course it's going to, they have high LDL, but just to prove that, it's largely going to be epidemiology because it's unethical to not treat someone. So this is just one example of what you get from treatment, and I'll give you another one in just a second. This is a Dutch registry of about 2,000 individuals, and it was a natural history study. They looked at pre-statin, before statins came out in the 90s or so, and what was the natural history of people with FH. And then in the post-statin era, those that chose to take a statin, what was their history? So this is the no statin, and you can see, you know, about 10 years, you have about a pretty significant, almost a 30% event rate of coronary heart disease. So pretty significant. And those that were on statin treatment, you can see the risk is markedly different. And when they compared to the Rotterdam Health Study in green, which was individuals without FH, it was almost superimposable, meaning if you start statin treatment early, show you a study on this in a second, you can essentially change the natural history and normalize the disease. And so one critical part about making this diagnosis is, of course, treating the individual. We'll talk about that a little bit more. But the other critical part, and to me, this is the one that's always missed. Now, again, Dr. Amit and I were talking about, I work with fellows, I was our fellowship director for a long time. You know, the number one thing they miss is this, and actually a lot of our faculty too, which is family screening. This is the critical opportunity. This is the critical opportunity, is when that light bulb goes off and you're thinking FH, the very next thing should be family screening, family screening. So this is just a thought experiment about Cascade. We use the word Cascade screening. You know, if you find an individual in Oregon, you screen, you know, their parents, their children, their siblings, and you keep going. When people have modeled this, for every one proband, one person with FH you find, you get about 8 relatives. And each one of those relatives, this can be life-changing to make that diagnosis. So really, the first thing you do when this crosses your mind, say, what are the implications? Of course, I'm going to treat their cholesterol. The implications are family screening, and we'll talk about how to do that in a little bit. Now, one more thought experiment about FH, and you know, when I see patients, we have an FH clinic on our Mondays. One of the hard parts is helping me realize why FH is different. You know, what's different than garden variety internet cholesterol that you read, right? And one of the things is the autosomal dominant family inheritance. The other is on this slide, a little bit busy, but you know, when we think about smoking, we think about pack years. With LDL, we should think about gram years, right? How many grams, area under the curve. Heart disease begins in childhood. And so one of the things, this is a thought experiment, if this is an individual without FH, this is the accumulation of gram years over time, right? And at a certain point, you cross the threshold when you develop heart disease, let's say at 55. Remember, when you have FH, your clock starts from birth. So this is the aha moment that I hope to get my patients to understand. Your gram years start from birth. Your cholesterol is high from birth. And so your arteries are bathed in LDL from birth, and then your slope is steeper and you develop heart disease much sooner, right? And this would be homozygous FH, where obviously I mentioned teenagers and young children that develop FH. So this is why treatment early matters. We'll talk more about that. But because the clock starts from birth, our cholesterol guidelines said the following. I know Dr. Meadham was a reviewer of this, and we incorporate this in our prevention guidelines. If you have an LDL above 190, not just FH, but this also matters in terms of lifetime risk, you start a high-intensity statin, Atorva 40 or 80, Rasuva 20 or 40, without calculating a 10-year risk. There's no calculation. The risk is so high that you can't use a calculator because those risk calculators, whether it's the pooled cohort equation or the PREVENT calculator, they don't include patients like this, right? And so their calculation, the risk calculation is going to be on a normal, average internet cholesterol type individual, if that makes sense, right? So no calculations, don't pass go. You see it, you start a high-intensity statin, and not a lot of discussion there. So really important point about those gram years from birth. I want to talk about children because I'm not a pediatrician. But I end up managing or co-managing with some of my partners a lot of families with FH. And the big thing is this study. This was a seminal study, and I'll give you the follow-up of it, of statins in children. Because you know, when this concept, it always sounds weird, starting kids on a medicine, you worry about their maturation and development, is this safe? But this was a seminal study, and I'll walk you through it. They took individuals, children with FH, and they were somewhere between, I think, 8 to 18 years old. And there were 200 of them, and they randomized them to pravastatin in the black down here or placebo. Now, in the placebo, their LDL was 237 and obviously didn't change. In the pravastatin, it was 239, but dropped by 24%. That's what pravastatin does. This is looking at the change in the carotid thickness, the carotid INT in different places. But the bottom line, on the pravastatin, it seemed to progress. Sorry, in the placebo, it seemed to progress. In the pravastatin, the carotid thickness declined, at least as a surrogate. But here's the most important thing with safety. We were about maturation, no difference in weight, BMI, LFTs, Tanner stage, testicular volume, et cetera. There was normal maturation, so it seems to be very safe in children. And this, to me, is the cooler study, which is they brought these, they looked back 20 years later. So this was published almost 20 years later from this cohort. And let me walk you through this as a little bit of a natural history study. So we talked about these ones that have FH, got put on a statin. Well, here they compared them to their siblings, autosomal dominant 50-50, so the other 50%, the siblings that did not get FH. And again, 20 years later, they looked at the carotids, and they looked exactly the same. So from a vascular biology perspective, you normalize the phenotype, right, that they look the same. But here's the interesting natural history. Their parents out to age 39, 1 in 4 of their parents had a heart attack by age 49, right? Pretty severe, pretty significant. These kids, when they watching them out to age 39, only 1%. You absolutely change the trajectory of these families, right? They're going forward. And so to my view, as I always say, it sounds strange to treat a kid, but you can take a horrible genetic disease. There's many genetic diseases that we think about, and that you can make them have a normal life if you start early. It's just when we think about cholesterol, it sounds weird. If we said this was cystic fibrosis or something else, it would make, you wouldn't feel that unusual about treating kids with a genetic disease. So the cholesterol guidelines are pretty clear, and this is the one that I think most of my colleagues don't think about and when I mention this to patients, but if you have a family history, right here, if you have a family history of early heart disease or significant hypercholesterolemia, you're supposed to check LDL as early as the age of 2, right? And statins are FDA approved. Here they said 10, but they're actually FDA approved at the age 8, based on that study I showed you. So we should not be waiting. Many of my partners at Children's would start statins at 5 or 6 years old because you're going to do it sooner or later. Why wait for the disease to get more manifest? And so the sooner we start, the better. And when I tell people this after the age of 2, they look horrified, you know? But you can, again, I showed you the data why that's really important to start early. One last thing for those, again, I'm not a pediatric doctor, but I said 190 in adults, but you got to remember kids have lower cholesterol ranges, right? So this is acceptable as 110 for LDL, borderline 100 to 130, and abnormal is above 130. 160 is the 95th plus percentile. So kids have a different range when they're under 16. Okay, so I set the stage for FH. It's much more common. If you're out seeing patients in the hospital today, someone with an acute coronary syndrome, you know, maybe 1 in 20 chance that they have FH. 1.2 million people around us have it. Imminently treatable, very simple, cheap medicines, and if you start early, you can normalize the phenotype. But we're not doing well, and we at UT are not, and you all have published some data as well, which I'll go over in a little bit. But I want to talk about how can we do better? How can we do better at making this diagnosis and then implementing treatment? I'll talk a little bit about genetics. I'm going to talk about electronic health records and then some other kind of interesting things that are in the works. So let me start with genetic testing. So why would you do genetic testing? You know, you can look at the LDL. It's high. It's not a secret. A few reasons. One is that we call it for Cascade, enhanced identification of affected individuals. We'll talk about this, but how we can improve that screening of family members, being more efficient using genetics. And, you know, I have a case that I'm not going to show today, but I've had many ambiguous cases where the child is kind of borderline LDL and you're not sure if they have FH or not. So you can clarify ambiguous cases about whether they have it, and we'll pass it on to their children. We'll talk about even amongst patients with FH, it tells us about risk, and then a little bit about some precision medicine things. All right. So in terms of using, so some people use a gene forward. You had Dr. Catherine Racing here a few years ago. He's a very gene forward approaching individual about using the phenotype, LDL, versus the genotype. And what I'm going to show you is, as most things in an election year, it's neither or, right? It's both. We can all get along here. And so this is Geisinger, which are probably the most kind of gene forward group around. They looked at their database of individuals, 50,000 of them, and did whole exome sequencing for a lot of diseases, including FH, not solely FH. And looked at the key genes for FH. What I want to show you is that out of these 50,000 individuals, they had 215 that were found to have a genetic variant for FH, about 1 in 256. We said 1 in 250, so it makes sense. And then they had another 46,000 which are variant negative. So they found a lot of people, And the first part about why genes first is interesting is because when you looked at clinical criteria, this Dutch lipid clinic, out of those that had an abnormal gene, they had almost half of them would have been unlikely by clinical criteria. So if you looked at clinical criteria, you would have missed them, right? You wouldn't have picked them up. And we'll talk about why that might be in just a minute. So on one hand, you're thinking, wow, genes can be very helpful because we'll pick up people you would have missed. But if you look at the denominator here, it's 215. This denominator is 46,000. And it turns out if you looked at possible possible, probable, or definite, there were a lot of people that the genes would have missed, right? So if you use genetics, you would have missed people that had it by clinical criteria. And numerically, because this denominator is so big, you miss a lot more. If you just do genes and don't look at the clinical phenotype, you'll miss a lot more people. So these two are complementary, in my opinion, and we'll talk a little bit more about the subtlety. It turns out that out of those that they found, only half were on a statin, less than half had a good LDL, and obviously the minority had had a diagnosis. So these were an opportunity for their population to do something different, but we talked about why it's complementary to clinical. One other thing, and this comes up a lot, people always ask me, they say, well, if someone's LDL is high, is it possible that you could have FH with a normal LDL? And the answer is yes. And this was I always hate to be anecdotal as an academic physician and say, well, what do the data tell us? And this is one study where they looked at 20 families. So the unit here is the family. And the family with these black shades are people that are that are affected clinically, but also written pretty small. These are the genotypes that they have in their family. And it turns out if you go through all these 20 pedigrees, these are just some, these ones in arrows are individuals that did get the gene if you look at how it segregates, but their LDL is actually normal, it's not high, right? And you say, well, how does that happen? Because they might have got a gene from the other side that lowered their LDL, right? So there may be one other question. Turns out about 30% of these families had a normal cholesterolemic carrier. So in families, 1 in 3 will have someone whose LDL is okay, but they actually have FH. You say, well, why does it matter, right? Well, because they can pass it on, right? And so it has to do with just saying you're fine, don't need to screen your children. That's not actually correct, right? Because that's the problem when we just use the LDL in terms of family screening. I also want to talk a little bit about precision medicine or a little bit about risk, about what else can we gain from knowing about genotype status. Now, I have to give my disclosure. I mentioned this at dinner last night. There is another Amit Khera, Amit V. Khera. He works with Dr. Katharaysan. He's done a lot of great work in preventive cardiology. He's been great for my CV. So, but this is his work, so I have to give him attribution, unfortunately. So what he did was they took individuals in a population study, and they looked at LDL bins. So looking down here, and this is the odds ratio for coronary disease. So let's take those without FH in blue. Pretty obvious, your LDL goes up, your risk goes up, okay? And then in purple here are those with FH. And essentially what he's saying is, for every level of LDL, so your level LDL is 220, it's really high, and we say FH, we mean you have a variant. When you have a variant, your risk is much higher. So meaning in my patients, and we'll come to risk stratification later, out of all my patients that have FH and we're deciding how high risk are they, when they have a gene positive, the risk is even higher, even for the same LDL. And why does that occur? One idea here is persistence, that when you have a gene, maybe from birth, it's been actually higher and more stable for longer. So having the genotype is important for understanding risk as well. All right. One other thing that's really important, and we'll get to genetic counseling in a second if you have patients with FH, and that has to do with the negative predictive value, if you will. So one of my colleagues, Zahid Ahmad, he's an endocrinologist, my partner in our FH program, published this. We used our Dallas FH cohort, so about 400 people that look like they had FH by clinical criteria. So they clinically, you saw them in clinic, you would have said they have FH. And then he looked at what proportion of them had one of the abnormal mutations, one of the genes. And it turns out 2/3 did not, okay? So that's tricky because if you're using genes clinically, 2/3 did not have one of the abnormal genes. And I'll talk about why in a second. And if you look at published data, it's variable, but in the United States, so in the Netherlands, they say 85% of people have one of the abnormal genes or mutation. In the US, we're seeing about 50-50, okay? So even if you clinically look like you have FH, only about 50% of the time you have one of the causative mutations. I'll explain that in just a second. And that's this, which is, it turns out there's probably phenocopies, meaning LDL high, but for other genetic reasons. So this is sort of LDL right here, about 50% of the time. We have other genes that are more minor, ones that do along with stratification. There's other copy number variation, meaning that the assays we have for the genotype are just not picking up these mutations because of the way that they are. A lot of it is polygenic. It's not one gene, but you get multiple genes from different parents, and those additively cause it. And finally, a lipoprotein A may be a phenocopy if it's very high lipoprotein A. So it's not that you don't have a lipid issue, it's just not due by one of these causative genes. Okay, so last thing on sort of clinical genetic testing in FH. So this is from the Family Heart Foundation. They offered their suggestions around genetic testing. Bless you. And here's what they say, that everyone should be offered genetic testing, right? Everyone should be offered. Some may decline, but for those that agree, you go down and do Cascade genetic testing. If it's positive, then you use that gene. So what happens, most of these companies, if I got tested and I had an LDL receptor mutation, most will screen any family member for 90 days for free for that pinpoint mutation. So we've done that before. We've mailed kits all around the country. They don't have to be in Dallas. And we'll find out a cousin and a family member in New York or somewhere else. And we've actually brought children in. Once I had a clinic with 8 little kids and they were all spitting in cups, and we sort of find out right there and then who has FH and who doesn't. So it's pretty efficient by doing that. If they decline, then you just use their lipids, which is fine also. And then you decide whether or not they have FH. Remember, if their genes are negative, if the genetic testing is negative, you don't know they don't have FH, double negative. You don't know they don't have FH based on what I told you. Just means we may not have one of the genes, or it could be a phenocopy or something. So I always tell patients, full disclosure, even if you have clinical FH, there's a 50% chance we don't find one of the genes. It doesn't mean you don't have the disease. We just can't use it to screen your family, if that makes sense, okay? All right, I'm gonna change gears a little bit. I spent a lot of time on sort of the background and the genetics. I wanna talk a little bit more on finding. And so we talked about genetics. I wanna talk about healthcare systems work. There's many ways. We talked about population genetics. We can use high LDLs above 190, and we can also use AI and machine learning algorithms, which obviously is very in vogue, and I'll talk a couple examples about these. First example is your own. I wanna see if I quote this right. Dr. Minimo, correct me if I don't. You all sort of looked at your own data several years ago. In your EHR at that time, you looked at about 400,000 individuals and looked at this 80% likelihood FH based on a very high LDL and some other criteria, and found 841 that looked to have FH. So prevalence of 1 in 470, a little lower, but that's probably because people were on treatment and so their LDL looked better. So that's what you found. And interestingly, out of those that look like they had FH, there were lots of opportunities, as there are everywhere, and that's a purpose of doing this, is to find opportunities. About 64% were on statin, 34% were deemed adequately treated, meaning 66% were not adequately treated, a real opportunity, which you all discovered, and only about 4.3 were diagnosed with FH, meaning, again, you all uncovered some real opportunities in your healthcare system, as all healthcare systems have around FH. So using the EHR, even a very crude tool, we can identify people that are under our noses that we're managing, but they have a real opportunity for improvement. We did the same thing a few years ago, and I kind of knew the answer to this, that we would do poorly because that's what everyone is around the country, but I had to prove it to then get the initiative going around our FHQI, because many people say, well, we won the Nobel Prize here, of course we're doing a great job, and I knew we weren't, so I had to show them. So we took a little bit different approach. We had 30,000 individuals, and then we looked at those who had residual LDL above 190 at 220 and had a great medical student sort of go through their charts. And it turns out only about 20% were currently on a statin with an LDL that was quite high. Most had a follow-up appointment, so that's good. But when they made that appointment, about half the time, no one did anything with an LDL that high, And then again, about less than 1 in 5 or so, 1 in 5 times did they actually send them to a specialist. So a lot of inertia. People are seeing these labs. These are not normal labs, and then not much was happening, obviously. And that's leaving aside, family screening and things like that. One of the challenges with electronic health records is getting into the chart itself. And because a lot of these fields are in provider notes. And I want to show you kind of something that makes sense here about documentation. So in terms of FH diagnosis with an LDL above 190, it was only mentioned about 14% of the time. Mentioning even just, did they even ask or document yes or no, family history of dyslipidemia less than 1 in 3. Any documentation around xanthomas or ARCUS, just in our clinic notes, we're not documenting it. So it's very hard using the EHR to figure out if someone has FH or not, because we're just not including these elements and not looking for it. So one of the things we've done in the last few years, we pivoted. I'll show you 2 stories about that. One is just going to a simplistic LDL above 190. This is a little bit old. We're up to about 9,000 people that have ever had an LDL above 190 at our institution, and we're going through them systematically. Just I took out names here, but just to go through here, these LDLs, if you look, just if you scroll, their highest LDL, 290, 290, 290, 290. When you look at this and you just, you just see all kinds of opportunities. Even their last LDLs are 290, et cetera. So this is a very simplistic way to see who's at risk and who you might identify with potential FH. We went through these a little bit, just one sort of teaching point. You know, I always like to set the stage about some of the research we do and some of the initiative. And we wanted to see what did they look like when we actually took these individuals. And so we bin them into categories of LDLs here. And there was 100 in each category. And we said, well, who's the highest yield? Who should we go for first? And you're intuitively saying we should go for the very highest LDLs. But it turned out when we looked at secondary causes, about half of these people had a secondary cause. Nephrotic syndrome, hyperthyroid, obstructive liver disease are the most common. And we found the most common by far was nephrotic syndrome. But all told, about 25% had a secondary cause, and it seemed to be this middle category was less frequent. This is the area that we're targeting first, these sort of 200s in our program, but it was very helpful to sort of go through that to see that systematically. All right, so we have simplistic things we can do, LDL 190, it's the 2000s, machine learning, very exciting. And so I'm going to share with you sort of an ongoing project with machine learning. This is from the Family Heart Foundation, where they had a machine learning called Find FH. And so essentially what they did is they took a model with 1,000 individuals that had FH and 60,000 that did not. And they basically created a model using multiple institutions' data to see if they could find FH. And the idea here is this, that again, if we're using LDL, the problem is some people with FH are already treated, and so we'd miss them if we just use LDL. Now, they reported that their accuracy was 87%, or around 80s, depending on what data set, that for their accuracy for finding FH with this machine learning was pretty good, and so real opportunity. So we're part of a collaboratory, we call ourselves. There are 7 centers here. Here's our data at UT Southwestern, where each center has applied this machine learning algorithm into their data set. We learn from each other about how to best approach individuals and patients, and then see if we can improve our care for patients with FH. And I'll just show you just a couple of learnings from that early on. So I never like to do something, and I never want to call a patient and say, you have FH, unless I've actually looked at the data in detail, and I believe it. And so we went through and validated that data, and we looked at sort of how accurate is this, right? I know you told me this, but I got to see it in my own data set. How accurate is this model? And this is Simon Broom here. This is Dutch Lipid Clinic. These are sort of quintiles, increasing score categories. And bottom line, all told, accuracy in terms of possible or definite was about 20 to 30%. So not great, right? You're saying that's not great. Is that enough to sort of, it flags someone, you call them and say you have this genetic disease, and if they don't, that's a big problem. It turns out that it's not so much, accuracy is probably not the right word, okay? And the reason accuracy is not the right word is because it turns out it wasn't that they didn't have FH, we didn't have the chart elements to tell you yes or no. I've called them more unknowns, right? And this goes back to how we enter data, because we don't know about xanthomas and genetics and things like that. So most of it was actually unknown rather than negative. And so I think as we think about machine learning algorithms, as we move forward, there's accuracy and then there's clinically actionable. And I'll tell you what I mean by that. When we went back through their charts, maybe a third had FH unlikely, but a lot of them just had limited clinical data, were already in care models, but about half we felt still were reasonable for us to reach out to them. And out of those, when we looked through them, about half of them had an LDL under 190. And so the point here is this, that there are different ways to approach this, right? It's like an elephant, the tail of the trunk. One is you can go in and use EHR. One is you can use LDL above 190. Here, the benefit of using machine learning is you could already be on treatment and we can still pick you up, right? We could still identify you because half had an LDL above less than 190 and still has a real opportunity. So that's the good news, is that we have these opportunities to identify individuals. So here's the bad news. The bad news, and what is really the aha moment to me, is implementation. So just because you identify someone doesn't mean, we're all done, everything is good, everybody is well treated. And this is pretty sobering when you look at Penn. So University of Pennsylvania was one of the first entities to apply this machine learning algorithm. And they had what I call a low touch, high throughput. They had 5,000 people identified using this Find FH. They contacted their PCP, sent them letters, invited them to clinic, and of all these 5,000 people, 3% scheduled a visit, 3%, right? So this is really important, because if anything that I've learned is stages of change, right? So the first is we need to find these people. And then we realize finding is not the problem, right? The gap here is implementation, right? And so I'm going to share with you one last thing about what we're doing about implementation. At UT Southwestern, we have sort of now we've a formalized program with identification, and then a lot about outreach and treatment informed by what we're learning in this collaboratory. This is preliminary data, actually before we really started using FIND, about some of the things that we're doing. This is in review, but we had 108 individuals we contacted when we're using LDL above 190. Only about half were on statin. Their highest LDLs were 260s. About 1 in 3 subsequently had a visit, better than 3%, not perfect. And out of those total denominator, 22% had a change in care, meaning someone did something with their lipids, they had a diagnosis, they had family screening. So not great, 1 in 5, but could be worse based on what we saw. Things that we wanted to say, well, what is it that's working? What is it that's causing change? And this is when we involved their PCP, that made a big difference. When we had more contacts, 2.2 versus 1.5, so intensity of contact, involving their PCP were informative in terms of invoking change. Last thing I'll tell you is an interesting story about blood donation. Serendipity, we have a large blood donation center in North Texas. They do several 100,000 blood donations a year, and they approached us to think about doing research with them. And if you think about it, blood donation has a huge volume of samples. They're generally younger blood donors, and they're not necessarily seeing in a medical encounter. And I don't know about you all, but in our blood donation center, they give us total cholesterol. They give you your lab values back, your cholesterol. We said, wow, I wonder if we can use blood donation to diagnose and identify FH. And so this was our pilot study several years ago. And out of 1.2 million people in their data set, if you use what's called MedPed, which is just total cholesterol and age, turns out 1 in every 339 blood donors has FH. Their total cholesterol was 332 on average, and their mean age was 32 years old. And again, these are not people being seen in the office necessarily, right? So real opportunity. That's led to a trial that's ongoing. We were fortunate to get an implementation trial. Cardiology trials have to have fancy names. Ours is called Donate FH. We did a 1-year planning phase where we interviewed individuals with FH, and really I have 2 implementation scientists, PhDs, that work with us, getting in their brain about what would make them want to get treatment when they're not in a doctor's office and they just get a letter from us about a genetic cholesterol issue. And then right now we're in a randomized trial phase. We've had 29 patients randomized to baseline cholesterol, notification with this implementation bundle of teaching and explanation versus usual care, and then looking at change in LDL at 6 months. So hopefully someday I'll be able to tell you the follow-up to this story in just a few years. Okay, I'm going to finish with treatment. So we talked a little bit about the problem, about the opportunity, ways that we can better identify, and some of the evolving things. And I'll finish today with treatment, coming back to office-based care patients that we might see as well. All right, so we had dinner with our dietitian friend last night. I agree with this completely. Lifestyle still matters. It matters no matter what the disease entity is. This is one study that looked at it. It's observational, but they looked at individuals with FH. Now here is no mutation. Here is with a mutation. But the bottom line, if you look at lifestyle factors, if they are favorable, if they're unfavorable, your risk is much higher, intermediate, lower, even if you have FH mutation or not. But amongst patients with FH, at least observationally, lifestyle does associate with risk factors. So your LDL is important, but so is your lifestyle. And so we should always think about lifestyle counseling. Now, when it comes to treatment, the problem is that there's guidelines and guidance, and most of this is guidance where it's expert opinion about what to do with individuals with FH. And most will say, if you have FH, high-intensity statin, 50% reduction of LDL, but there's some variability on what that LDL should be. Some say 160, some say 100. It's really arbitrary, and we pull it out of the air. This magic number of if you have FH, remember in our case, that person had an LDL of 107. Is that good enough, right? What should it be? And this is where it's vague currently. So as you all know, there's many new treatments available beyond statins. Mike and I were talking about ezetimibe. There's our gentleman here is out there with evolocumab, alirocumab. We also have bempedoic acid, oral treatment now, and then inclisiran, which we're using at our institution as well, which is also a silencing RNA for PCSK9. So we have lots of new therapies, and you're thinking, yeah, we have a lot of new treatments, and hold on for a second, because these are things that are available or in study. So if you think we have a lot now, just wait, including CRISPR-Cas9. Dr. Katharaysan came and talked to you about that, where he's gene editing for FH. So there's a lot of interesting things coming. So it's not just we have a statin and we're done. We have a statin and then what? And that's the big question, and then what? And the first is you have to realize that there's heterogeneity. Again, Dr. Meadham has done a lot with risk. there's a lot of heterogeneity. Not all patients with FH are the same. And this is one study called SafeHeart where they said amongst patients with FH, can we come up with a risk score to splay them out in terms of the risk to see who needs more intensive treatment or not. And so some guidelines, Europeans talk about if you have a patient with FH, you should use this score. It includes the characteristics down here. I want to make a point for lipoprotein A, which should be measured in all patients with FH because it seems to be a disease modifier. But the bottom line, in those who have none of these characteristics, as you march up, with more of these characteristics, the 5 and 10 year, 5 blue, 10 orange increase significantly. So first is just there's heterogeneity. Second, and I see this clinically, and this drives me crazy, but it is true. I'll see someone who's 80 with an LDL of 220 that gets referred or we pick up in our program, and somehow if we do imaging or otherwise, their arteries are clean. And it's not deterministic, it's probabilistic. LDL is still probabilistic. And this is an example of that. And let me walk you through that. So as Dr. Katharasen's group has shown, there's other genes. We call them polygenic risk scores, 6 million genes that can inform coronary disease, and you can have a bell-shaped curve about where you are with that. And what they did is they took individuals that were non-carriers, they didn't have FH, and we take this, and those that had their polygenic score was low, meaning lower risk of heart disease, they had a lower risk. Polygenic risk was high, they had a higher risk. Well, let's superimpose that on individuals with FH. If you have an FH gene, but a low gene for polygenic risk score, a low score, you weren't actually much worse off, right? So meaning one aspect of this is your FH, the other is what are the rest of your genes, right? And they both matter in terms of deterministic. But if you had FH and a poor polygenic risk score, you were really in trouble, right? And so there's still heterogeneity. They're not all one type of patient with FH. So that brings me to imaging, again, something you all have done a lot of. How you doing, Dr. Berlakis? Good to see you, old friend. We used to work together for many years. It's about when he showed up back then too, but good to see you. So you may take individuals, again, there's heterogeneity. They all have FH, but some will develop heart disease, some won't. Statin plus or minus ezetimibe. But why might you use imaging? Where might that come in? One is intensity of therapy. What number is good enough? We have lots of new therapies, and this is just LDL, but we have GLP-1. Should they be on aspirin? We have new LPA treatments maybe coming next year. How many of these medicines should they be on? What's it worth? And this one's a little bit more evolving. We had a nice discussion about this at dinner last night about monitoring. Can we monitor how they're doing with serial imaging? So again, work that you all have done a lot of. I was hearing about the EBCT coming back in 1998. You've done a lot of imaging work here and ongoing. I do want to just talk a little bit about, again, this heterogeneity in patients with FH. So these are blue, one cohort of 102 individuals with FH. In green, those without FH. And then they all underwent calcium scoring, again, something Dr. Meadham has contributed a lot to. Importantly, out of those with FH, LDL 280, about half had a calcium score of 0. Meaning, again, it doesn't mean automatically you're going to be this greater than 400 because you have FH, right? And so this says, there's heterogeneity. Maybe we can use imaging to help stratify who needs more intensive therapy or not. So that's the positive. The negative is the negative predictive value is a little more challenging in FH. So on the left, let's say your individual has FH, they're younger, you do a calcium scan and they're scored of 0. What can you tell them? Now, in the general population, this is something called SCAPUS in Scandinavia. They had 25,000 people underwent a CT angiogram. If you had no calcium, you only had about a 6% chance of having any plaque. So you not a very high chance and very unlikely to be obstructive, but there was a small chance you still had some plaque. But in FH, particularly because they're younger and they have higher LDLs, if you have a score of 0, this was a recent pooled cohort of several studies, 1,000 patients with FH getting a CT angiogram, you have a 1 in 5 chance you still have plaque, right? So you're not excluding plaque as well. The negative predictive value is not as good with a calcium score of 0 in individuals with FH. One last thing, we were talking about this last night about what is coming and beyond coming. You're doing it and others as well. But there's AI-based quantitative. So if you end up going a CT angiogram, this is from Clearly where they use the AI to quantitate how much atherosclerosis you have. This is actually one of my patients where they tell you that he has 58 millimeters cubed of total plaque, 48 is calcified, 10 is non-calcified. Theoretically, one could serially screen and see what happens to the composition. Is he calcifying more? Is the plaque increasing? If it made a difference as you're going through treatment. Okay, and last thing as I wrap up is, this is theoretical, but let's talk about what guidelines are saying about imaging. This is the most recent statement, and they said in the International Atherosclerosis Society that calcium is useful, so part 1. but that we shouldn't use it to track treatment. I think we know that many people that work with calcium scanning, but can be useful, gave it a class 1. But they also threw this one out there. In asymptomatic patients, imaging of ASCVD may be considered for monitoring the effective. Weak recommendation evolving, but something we'll see in the future that we may be doing more of. Time will tell. Let's go back to our case. I gave you this individual. It's my favorite thing to do in teaching when I'm with our house staff. The critical point here is back calculation. You have to do the math, right? You see this patient, you can imagine this could be seen by 100 PCPs and it would go in cardiologist and go under everyone's nose and no one picked this up. The issue here is he should have a 50% reduction in his LDL, just about 46 to 50%. You back calculate his starting LDLs over 200. And we miss this all the time, because we don't back calculate that if you're on this statin with that LDL currently, and you're taking it, you have to be taking your statin, your starting LDL was really high, right? And so you have to always back calculate when you see these individuals. So his PCP had actually received an alert about possible FH. When you look back, I always go back to Khera everywhere, as far back as I can go. He had LDLs as high as 208. With that family history, he looks like he has probable FH. He absolutely should be offered genetic testing, which I talked to you about. His children and his siblings definitely need to be screened, both by LDL, possibly by genetics. He elected shared decision-making about a calcium scan, not super high, but the 96th percentile, 92nd. He also had a high LPA, which is a toggle factor, and then one elected to add PCSK9 and we're doing this for forever, essentially, right? And his LDL came down nicely. So in summary, FH is common, about 1 in 250, significantly increases the risk. It's underdiagnosed and undertreated. There's a real opportunity for all of us here today. We know that high-intensity statin is the starting place, and cascade screening of family members, always important. Genetic testing and new algorithms are coming, but they're all not the same. Even though they all need to be treated, they're all not the same. There's heterogeneity, and we talked about some ways we may apply imaging or other tools to help determine who needs the most intensive treatment. Okay, well, listen, thank you again. It's a true honor to give this Kevin Graham lecture, meet some new people, and make some new friends, and thank you so much for having me.
That was fantastic. Thank you. We definitely have some time for questions. Kevin.
Yeah, I was a little surprised. Great lecture. Really enjoyed it. I was a little surprised with the slide about the elevated risk with FH when controlling for LDL levels. So I'm wondering, do you know with people with gene-positive FH, if you account for lifestyle or lifetime exposure to atherogenic lipoproteins, do they still have elevated risk?
Yeah, good question. It's a good question. You know what Amit Khera, my namesake Khera, did in that study, if you go deeper into it, because of population cohorts, they sometimes had serial LDL levels, and they found out with those with genes, they actually did see persistence, that the LDL was staying higher. And those that didn't, it looked like the LDL was more variable. Now, they didn't do what you said, which is did they adjust for it and see did it persist? That was, they just inferred that. There have been several other studies, too, that when you look at people with, and they do this a lot in Japan, where they MRI or ultrasound your Achilles. So so the thing about xanthomas is they're obvious, but you can imagine it's sort of a density thing, how much you have. But when they look at that as a continuous variable, when you're gene positive, you actually have thicker Achilles, more deposition. So this all kind of comes together to suggest that mechanisms of why that increases risk to gene positive.
Is there any difference in how people who are FH positive or negative respond to therapy?
Yeah, good question. His question was, is there any evidence of people who are gene positive respond to therapy? You know, for heterozygous, less so. There's probably some heterogeneity, a little bit less so. I'll come back to that with homozygous first, and then I'll back to your question. Homozygous is different, and because you can have completely null receptors, they don't work at all. Because remember, we have 2 copies now, so you have null receptors, they don't work at all, or they can be defective. So PCSK9 inhibitors have been studied, monoclonal antibodies. If your LDL receptors work a little bit, then you get some reduction, maybe a 15% reduction in LDL. But some people with homozygous FH have no response whatsoever. And those people have no receptors, they just don't work at all. So I guess theoretically, if you're heterozygous FH and a null versus a defective receptor, that might matter a little bit. But for all intents and purposes, it didn't seem to pan out quite as much. Probably the one issue is if you have very high LPA. I have a patient with LPA of over 700 that also has FH, double gene knockout. She's 36 with 3 vessel coronary disease. You know, those people don't respond quite as well to LDL lowering because part of that LDL on the lab is a very high LPA, which doesn't respond to our usual therapies quite as much. So that's sort of a phenocopy that may not respond quite as well.
Great lecture, thank you. What about non-coronary artery disease in these patients, such as the carotid artery and aortic valve disease
Yeah.
later in life?
Yeah, thanks for that. His question was other non-coronary disease. The aorta is easier. They definitely, particularly homozygous, get aortic stenosis. I mentioned that young child in the beginning. So patients with homozygous definitely get aortic stenosis. Even some supravalvular, it's not always even valvular. Heterozygous, if they have very high levels, can. As I mentioned, LPA can be a concomitant factor that can accelerate that. You know, the thing about stroke is it's been variable in the literature, which is a little bit strange. We know there's coronary disease, but stroke's actually not been shown consistently in terms of increased risk of stroke. So it does, you know, beg the question as to why is that not as consistent? I'm not sure. You know, we ended up, sometimes what we do, because these patients are younger, calcium score is 0, this or other, sometimes we get carotid scanning because there's been some data about if you have residual plaque, your risk is still high. So I do think it matters to consider that, but I will say that the data has been less consistent about stroke risk in FH.
So thank you for that talk. It was by far the best FH talk we've ever had here.
I wonder if it's the only FH talk you've ever had.
I've given a few. So you saw our data, and after we found that 4.7% recognition, we did actually identify some of those people and send out letters.
Awesome.
Very strong worded letters to them, thinking, well, this is how we're finally going to reach people. We got about a 1% return, even with our concerns. What strategies, so that didn't work, what strategies have you used and can be successful? Because, you know, as you point out, it continues to be a problem.
Yeah, thank you for that. I got to tell you, this is one that keeps me up at night. And I think, you know, and as providers, is that we all have stages of change, right? And so my first was just tell them they have it. Of course, everyone will come, you know, and that does the data. There's one thing anecdotal, but I showed you data at Penn, 3% showed to clinic. I mean, that we have to get past that and realize that notification, identification is not enough. And this is what's neat about working in this collaboratory and working with implementation scientists, because we're learning from each other. So Ohio State, not Ohio State, it's next to that, but they had started before us. And so we learned a little from them. Let me tell you a few things we've done. First is we iterate. So now we have sort of a care path, and we'll do 20, 30 patients, we'll pause, look at our data, and iterate, and then do the next one. So we keep iterating. It's not a one and done. Some of the things we've done was communication. So we have a letter, we have a MyChart, we have a physician email that goes to them in Epic, and we have a phone call. We've kept iterating that script. And how do we do that? We took our letter, we sent it to the Family Heart Foundation. They have a panel of patients with FH. They read it and made all kinds of changes. We used their language. They have different activating language. They said, you're not being strong enough in this letter. I thought the patient, you know, would recoil at that, but they said, you're not being strong enough. So we changed the language. So one is just iterating with that letter. The other was we were trying to be a little lazy, so we were sending MyCharts, and then maybe that's easy to do. And maybe we send a letter, maybe we call. We flipped it. And based on what they were doing, we actually send a letter at the same time the MyChart, because we learned from the other institutions when they got a letter and they could read it and digest it, when they got the call, they were more mentally ready for it. And so we do that now. We actually send a letter to MyChart. 1 week later, we give them a phone call. Our yield has gone up a lot, some, still not great, but as I've talked to the CEO of the Family Heart Foundation, you know, we're getting about 1 in 5. And to me, I lament that, but she says that's actually pretty good. You know, think of all those, you know, 1 in 5 out of 9,000. If we get through that whole list, that's a lot of people and families with Cascade that would make a difference. So I guess the bottom line I don't say is just iteration and realize that we just have to bring the patient voice in as to what appeals to them and then make it as easy as possible in terms of getting them the care.
My second question is around payment for the genetic testing.
Yeah, that's usually my question too.
So we've, you know, I've seen some people that came from Mayo that had LDLs of 250 and their parents had heart disease when they were 30, and they clearly had FH, and we got a letter from Mayo that said you're genetically negative.
Yeah.
And then with that letter, there was a bill for $3,000. So we haven't done any of that because of these issues around payment, but it's incredibly important. How do we get around that?
Yeah, so I'll be honest with you. I have a partner who's an endocrinologist who did the genetic testing. He genetically tests everybody. I'm probably less than 50%, and I'll tell you why. For many of the reasons, there's some slides I took out in the interest of time. There's a few problems with genetic testing. One is the patient's billing. At least for the companies we use, BTI, GB, Insight, some others, they usually will contact them and let them know what the bill is beforehand. We haven't had a lot of surprise billing, but it could happen. And so the patient's usually informed and can decline, but I can see how that can happen. I was on an email yesterday about our county hospital because we do some genetic testing, and this issue around payment and billing is prescient there. The second reason so that's number one is cost. Number two, and I didn't get into this, but if you get to the legal stuff, right? So GINA, Genetic Non-Discrimination Act, cannot discriminate against your health insurance, and your employer cannot. But life insurance and disability could. So whenever I bring this up, everyone doesn't want it, you know? It turns out it's probably not the proband where it comes in, it's their children, you know? And then it becomes circular. So we're doing this so that we can find your children, but if we do your children, they may not be able to get life insurance, you know? And then, so that's one of the probably the biggest limitations once we get full disclosure on that, where people will decline. And in truth, as much as it's interesting, maybe in a different world down the road, for most of the time, the LDL is sufficient, most of the time. But I have had ambiguous cases, shared decision-making, screening family members far away where they elect to do it. But great points.
What do you tell the patient who has concerns about lowering their cholesterol too much because they've heard it's bad for their body?
Let me see if I have this slide. I think I took it out, but yeah, you know, this is a whole talk in of itself. I'm sure you've Mike, you've talked about this a lot too. But you know, I go back to no, I don't have it. There's the things about PCSK9 inhibitors. Again, we have an exhibit. I heard a lot of that work was done at UT Southwestern. My colleague Helen Hobbs. And first is with the PCSK9 inhibitors, we've been able to see low LDL levels. It was a theoretical thing. So in Fourier, they plot on this axis LDL, this axis risk. And there is no floor, down to an LDL of 10. We wrote the editorial on the 8-year follow-up, and down to an LDL of 10, we see no increased risk, right? Less than 10, there may be a little bit of increment, so that's number one. Number two is Dr. Hobbs, who was one of the ones who helped discover the pathway for PCSK9. We've had pedigrees in Dallas Heart Study. There's a woman who got it from both parents at PCSK9. She's a knockout, essentially. She's 32 and her LDL is 16. It's been 16 her whole life. She's completely normal. Has kids, master's degree, everything. You know, no organ problem. Number three, Dr. Brown and Goldstein, in their science paper, I have this slide which I don't have in front of me. They back said in 1986, they think an LDL of 25 is sufficient for cellular function. You know, so you have lots of lines of evidence to say low is pretty safe. But I get nervous around single digits. Up to 20, I'm okay, you know? And I say one last thing, and you know this very well from some of your collaborations, but you also have to be careful about the measurement that low. The Friedwald equation from 1972 is not accurate that low. So you need to get an ApoB or direct may or may not actually be accurate either, but you need to make sure that it's actually, you're treating a number that's actually true. And the math doesn't work that well at that low of an LDL.
I had a negative 10 a couple weeks ago.
I think it's 2 years better than mine, so that's it.
Mike, just
Yeah.
very quick question. So the electronic records are amazing, but there's a vast amount of things we don't need. Is there any effort in terms of, because I see the effort of going through 9,000 charts with scholars, etc., but in a given practice, that's not practical.
True.
So is there any effort in terms of working with Epic or different charts? to
Yeah,
have
and thank you for that
highlight?
question. It turns out, again, there's a whole another talk I give on this one topic. It turns out I'm really lucky because our chief medical informatics officer at UT is a cardiologist, and our associate chief medical informatics is a cardiologist. So the number 2 guy, Majid Bassett, we actually, as part of our FH algorithm, he's actually been instrumental in implementing it in Epic. So that's exactly what we're doing. Our registry is now in Epic. We're 80% built out, where now we can do this tracking in Epic. We can find them, track them, and then we can actually look at what we're working on now is who's treated and not LDL achieved targets, et cetera. And then the other part is what everybody loves, right? Best practice alerts or health maintenance alerts, order sets. So trying to automate more of this so it's not so manual and calling, but can we automate this more and then track it in Epic? And the goal is if we can build something useful, not that we retain it or have any IP in it, that we would share it, you know, that others could use it as well.
Can I ask one more
Sure.
question? You showed that patient journey and graph, and for heterogeneous, I'm a surgeon, so this has been a fascinating talk. So as I understand that most likely they will cross that line at age of 35. But at age of 35, not many healthy people access healthcare. So do you think that is actually the discrepancy in how many exist and how many are diagnosed?
Yeah,
And how
your
do we
point's well
correct it?
taken. That was, to be fair, that slide was more of a thought experiment slide. So whether it's 35 or 40, the point is it's, on average, it's 10 to 15 years earlier. So that is shown. So your point's well taken, and this is the whole point about discovery and going to the children. Because if we wait, we're too late, right? Diseases manifest and the horse has left the barn at that point. There's some other innovative programs. I think that's how do we find it in children. In the UK, they have a cool program. It was a New England Journal of Medicine with a couple of vaccination in kids with LDL assessments. And they picked up a lot of kids with FH, and the best part is then they picked up their parents, reverse cascade, right? So I think your point's well taken. This is what gives me, it's really about children. How do we get back to the children? Even in our program, it's not even, when I see a patient that has coronary disease with FH, it's interesting, but that's not the person I'm concerned about. That's actually not the point of finding it, because I'll get their LDL down. It's about their family members, can we screen them, and starting early.
Well, that was fantastic. Thank you.
Thank you.